I may have mentioned it before, but these programs, the main expos and the mixers are probably some of the best value-added continuing education and actually PM you can give yourself. Not only just from the educational content, we're fine. Not only from the educational content, but I think you'll hopefully see maybe already, and especially by the time you leave here, you're gonna feel a little bit more buoyant and lighter and refreshed and recharged, renewed as a result of being around like-minded buds and souls. Help, if nothing else, I think it helps tremendously reinforce the importance of the work that you're doing and just kind of reminding each other that you're kind of all in the same kind of boat. You know, you get to heal up a little bit after getting banged around in your workplace. I spent about 22 years doing hospital biomed work after I graduated. And a lot of the concepts I'll be kind of touching on here, which is pulmonary medicine, a lot of the medical side of stuff, I was just ashamedly ignorant as hell. A lot of times I was asked questions about why we were doing something with a certain device, and I don't know, it's just because the way it works, you know, trying not to look too stupid, but you know, at the time I didn't realize how weak my understanding of some of these concepts were. And it also came apparent why some departments, some clinical managers didn't want our people around. There was a lack of trust. They maybe just didn't think that they knew enough to be working on these critical devices. So the whole kind of point of where I want to kind of go here is some of the relevance of these physiological clinical concepts to our own work. And what I hope to show is that we don't have to take these concepts, these clinical concepts, to rocket science level. You don't need a 6-month class, you know, diving into all of this minutia and stuff to be effective. There's just some really fundamental basic stuff that if we can up our game a little bit on these concepts, you'll find out that it just dramatically gives you a different sense of depth and awareness of what you're doing, especially if you work on ventilators, anesthesia machines, even little CPAP machines. It takes our knowledge and understanding to another level. And the other key thing it can do too, it can broadcast to our clinicians that you know, we're not just fixing people in the basement. We can interact on a turkey level with you to some level, and we get a lot of extra mileage out of being able to do that. So that's where we're going to kind of go through. We got a few things to go over, but again, we don't have to do an ultra detail. But the fundamental benefits, especially you guys doing ventilators, I'm sure, anesthesia machines. These are serious machines. They're therapeutic life support devices that, when they don't work well or they're used inappropriately, they kill people. I've done a ton of expert witness work on the side, and about 30 cases in general, and all but maybe 2 or 3 of them involved fatalities, not of just ventilators, but ventilators have been involved. So they're serious devices, and anything that we can do to increase our awareness of what's going on when these machines are quite literally become one with the patient. It's not a figurative thing, obviously, in our environment. We make deliberate electrical connections to patients' bodies, deliberate in hydraulic with our pressure lines, pneumatic connections with our vents. So the more we can understand what's going on with the patient, the more we up our overall game with all of this. Okay, so a lot of just general lay people, and even a lot of us, I think in general, we fundamentally think of the lungs as a just basic gas exchange things. What's going on? We just, oxygen, carbon dioxide, but there's a whole host of other features that the lungs are doing, the whole pulmonary system is doing. A lot of this stuff is all done basically below our level of awareness. But in addition to the gas exchange, which we'll get into heavily, the lungs and pulmonary systems play a significant role in keeping our body's pH, the blood pH, within comfortable ranges. If it gets too acidic, too basic, then the lungs play a role in helping regulate that. Protection from pathogens, filtering of the air. It starts right in our nose with the nose hairs. Have you ever done a lot of drywall work or spray painting without a mask? And you go into you look like a walrus, you got dust and everything. It's because those nose hairs have captured all that, and it's all the way down to the airway too, where the body is trying to protect what we're inhaling, filtering out garbage, vocalization obviously, but the whole airway we'll see, especially the upper airway, it's all designed to help warm the air. So we're warming the air, filtering and humidifying the air just through the process of breathing. So those additional functions to the gas exchange are also what makes the whole pulmonary system so wildly important. If you've ever had a formal class in physiology and anatomy, I think virtually all of the textbooks are organized by organ systems. We're kind of taught these things as though they're kind of separate standalone boxes. We have about 11 different ones, and I always kind of like this particular diagram because it kind of tries to encapsulate all these 11 of these systems. I don't know if there's 11 here, but we have about 11 organ systems in one kind of a unit. What the books often have trouble conveying, I think, is how interdependent many of these different systems are. So when we talk about the pulmonary system, respiratory system, we talk about it kind of as though it's a little standalone system, but it's actually, we'll see in a bit, very intimately connected to the circulatory, cardiovascular system, nervous system, endocrine system. All of these different organ systems all interact, almost all of them very, very at an unconscious level, trying to keep us in homeostasis or a sense of balance. So it kind of illustrates that interdependence. If you've ever had a bad burritos or a case of norovirus, you can appreciate the one big long pipe, inlet and outlet, 20 feet up. You know, that's kind of how I want. But anyway, when we talk about the cardiopulmonary system, sometimes it's referred to cardiopulmonary, is because of the inextricable relationship that the lungs respiratory system has with the circulatory system. Very, very tightly coupled, obviously, in that just loosely venous blood, which has been kind of mostly, not mostly, but significantly deoxygenated by tissues who are quite literally sucking oxygen out of the blood. That venous blood returns to the right side of the heart, superior vena cava, draining all of the venous blood from the head, neck, and inferior from the lower extremities into the right atria, through the right ventricle, off to the lungs, where it gets reoxygenated, if you will. Carbon dioxide is released, and then the whole process just starts all over again. But when we think about the respiratory system, pulmonary medicine, think of it kind of, it's intimately tied in to the circulatory system as well. We typically refer to the lungs and the whole cavity here with upper and lower respiratory system. And obviously, you know, the upper is where we get a lot of our infections, colds, COVID comes in through this part of the respiratory system, nasal cavity, tongue, larynx, pharynx. We've got like 3 levels of the pharynx here, and there's actual lymphatic tissue back there. So it's a protective place. So you got garbage and pathogens coming in. We've got tissue back there that'll try to encapsulate that junk, prevent it from getting farther down into the airway. So if you've ever had tonsils taken out, they become repeatedly infected. It's because of the location of those protective tissues is right where we're bringing stuff into the airway. If you ever had a nosebleed, it kind of bleeds like a pig because it's highly vascularized, our nose, nasal cavity here, because we're doing a lot of warming. Warming and humidification of the air is starting right in this area here. So one way to warm, you need heat exchangers. So we got a lot of vascular, a lot of blood supply in the nose area, in that area there, that helps add the heat. Okay. Then we move down past the, we've got a little valve here, that the glottis, that prevents, when we swallow, prevents food from going down the airway. If you've ever had any catastrophes, there are disastrous cases where a patient maybe has been tube fed and the feeding tube gets sent down the trachea. And you're pumping food now into the trachea, and you got a serious mess on your hands. And then we have the lower respiratory system. You'll see it a little bit, the trachea and the lungs, bronchi. Okay. But you see the laryngoscopes, the RTs, and the pulmonary guys, the anesthesiologists, they're the masters at intubating patients that need to be put on a ventilator. And if you've ever seen them, the really good ones, I mean, it's just kind of amazing how they'll take this tube and they don't even need a laryngoscope. They can just walk it right into the airway. And if you've ever looked at an endotrach tube, they come in different sizes, obviously, for different size patients, but they all have basically the same kind of thing with the connectors on the end. And they also have a little air-filled balloon at the tip. And that's obviously there to seal the airway. Because if you think about it, we're pumping gases in and out of the tube. So we obviously have to seal the trachea off, otherwise we're going to have a very diminished functioning thing going on here. But all that balloon also prevents vomitus. If the patient should throw up, that inflated bulb will prevent the vomitus from going into the lungs. Have you ever had general surgery for anything and you come out and your throat's a little sore? If you ever had that done, this is why. You're getting a little irritation in the trachea from that tube. Okay. But fundamentally, the lungs are divided into lobes. The right lung has 3 lobes. It's a little bit larger than the left because we got a little notch here in the left lung for the heart to play in. And this, if we look at this transverse view, what we can kind of see here is this little space. It's called the pleural cavity. This little space outlining the lung. This is a real small fluid-filled space. It's virtually very similar to what we have around the heart, the pericardial cavity around the heart. There's a small amount of fluid, clear serous fluid that surrounds the heart, and it dramatically reduces the friction of the beating heart. So the heart's torquing away in the chest. We got this nice slippery fluid around it that reduces the friction significantly. And we get a little bit of that same kind of friction reducing effects with the pleural cavity and the pleural fluid, but the pleural fluid we'll see also has a significant role in keeping the lungs inflated, keeping the lungs basically stuck to the chest wall. If you ever tried to move 2 pieces of glass with a little bit of water in between, that surface tension in there, you can't do it. You can't pull them apart. And we get that same kind of benefit from that pleural space. If that space becomes punctured, normally, and this is something we kind of often maybe don't think a little about, but there's actually a little bit of a negative pressure in that pleural space, just a few millimeters of mercury vacuum. So there's a little vacuum in this space, and that little vacuum helps keep the lungs attached to the chest wall. Unless we get a puncturing chest wound of some sort, knife or traumatic, whatever it was, and we lose that vacuum, that's what collapses the lungs, and that's what atelectasis is, see the term coming up, but that's what will collapse the lung if that should happen. So literally, just, and of course, a collapsed lung is not going to be useful for anything. So we have to get that air out of that space, and this is what that would look like under a chest X-ray. You see tons of black space in there because the lung is collapsed. That was actually a procedure somewhere back in the 20s for treating tuberculosis. There was some clinical mindset at the time. You remember all throughout history, we've had a lot of weird, bizarre things we did to patients, like in the 50s, incubator, the oxygen in the incubator, a little bit of oxygen is good, let's give the baby more oxygen. We blinded all these kids. Well, in the 20s, I think maybe somewhere in that era, they used to think if they intentionally collapsed the lung, that would help treat tuberculosis. And then they would hope the lung would kind of collapse, re-inflate eventually, but that got debunked eventually. But if you ever see these chest drainage things in your critical care, you know, say maybe on the floor, maybe hanging off the side of the bed, we use these to evacuate both blood, which is hemo. So if we get blood in this space, and this can happen after surgery, trauma, all kinds of things, you can get blood in there, we have to get that out of there. Same thing if we had air in there, a pneumothorax, we have to get that out of there. And one of the easiest ways, we can put in a chest tube and we connect it to one of these drainage devices, and it just plugs right into your wall vacuum. And the sweet thing about it, it's just a passive device, but the way the chambers are set up, there is a water column that is used, filled up, and the height of the water column limits and dictates the amount of vacuum. Because you clearly wouldn't want to just take 100 millimeters of vacuum from your wall and try to suck somebody's, their guts would come out of that. So you don't want to do that. But this suction, these drainage units with that column of water basically regulates the wall suction to a safe level depending on the height of this, typically 20 centimeters of water. So then it's graduated so that nurses can keep track of how much fluid is being removed. So if you see bubbling the next time you're in the unit and you see a chest drainage, and if you see little bubbles going on, that means that's a good thing, because it's venting excess vacuum back out to the atmosphere. It's going through the water and it's bubbling back out. So that's how you know it's working. In other words, if there's no bubbles there, you've got an issue. Okay. When we look into the lower airway, lower respiratory tract, you'll see the trachea, and this is going to start to branch down at the level of the carina as it bifurcates. The trachea bifurcates into left and right bronchi, and then there's about 25 continuing branches of these airways here, and all of these they're rigid tubes lined with cartilage, so it kind of looks like the dryer vents tube, you know, the plastic spiral in it or a spring to it. It basically, the cartilage prevents the tube from collapsing on itself. So you'll see cartilage around that kind of tube, making it a rigid tube. And what's also wild, the inside of those tubes are lined with special, there's mucus in there, so it's a, you know, slippery kind of a fluid in there, but there's also special cells in there called this mucociliary escalator. They're little like grass, it's little cells, little cilia here, and they're constantly moving upward. The constant little motion moving upward. So if you get a particle of junk in there and you start coughing your guts out, it's something got trapped in there, and those little cilia are moving those particles up to where you ultimately end up swallowing it. So it's another protective element in there to keep junk out of your airway. So to help again, the mucus helps keep things, adds to the humidification, keeps things moist, but it also helps keep debris out of there. Some of these branching issues, if you actually could look at this, and some of these little models have tried to do that, you can start to see where they're, again, I don't remember exactly, but it's like 20 to 25 branchings of these bronchi to where they ultimately end up in these terminal bronchioles. We'll see that makes up our pulmonary tree on the left and the right side. Okay. And the whole ultimate goal of all of these structures, right from air coming in through the nose and the mouth, all the way down through the whole lower tree here, ultimately is to bring the gases to the level of the alveoli. These are little air sacs. I think, yeah, we'll see it a little bit. But ultimately, it's to bring the air down to these little air sacs, which are called the alveoli. These are like grapes. You can kind of think of like a thin grape skin with no grape inside of it. Really, really incredibly fine air sacs. And surrounding each of these little sacs is this massive mesh network of capillaries, pulmonary capillaries. So every little air sac is just surrounded by these small little capillaries. And again, I think I may have had it in the last lecture, but we've got thousands of miles of capillaries throughout our whole body. It's over 10,000 miles. It's a number I can't even get my head around. But every cell in the body, in order to survive, needs to be in relatively close proximity to a capillary in order to get its nutrients, to get rid of its waste, to get oxygen. And in order for the gas exchanges to occur, to take place, all of these little alveoli are surrounded by this mesh of capillaries. And we'll see a little bit more about how that works in a bit. But the surface area of these alveoli in both lungs, some of the estimates I've seen are like over 800 square feet. Like half of a tennis court in surface area of just all of these, the area of these little capillaries, these little alveoli. And that plays a tremendous role in the speed with which oxygen can pass over in close proximity to these capillaries, take in oxygen and get rid of carbon dioxide. And you can kind of see at the level of the alveoli, there's basically just two layers of membranes between the alveoli and the capillary. And in capillaries, typically blood cells are quite literally passing through their almost single file. They're like 5, 6, 7 micrometers in diameter. That's the size of the capillary. And some of the blood cells actually have to torture their way through because they're twisting and they're squeezing through these small little capillaries. That's why the blood cells only last for a few months, 120 days or so before they have to get recycled, because they're getting banged up by trying to squeeze through these little spaces. But you can look at the dimensions here. A blood cell, one blood cell is 5 to 7 micrometers, and you can see how incredibly thin the layer of these membranes are. And this is precisely how and why oxygen in the capillary, in the alveoli, is able to diffuse across these really, really thin membranes into the blood, and vice versa. We'll see eventually how carbon dioxide is able to also move from the blood out into the alveoli to be exhaled across these incredibly, incredibly thin membranes when they work well. There's a whole host of diseases that we can screw that up. Anything that messes with this interface here in terms of thickness, this is what some of the fibrotic lung diseases, if these become real thick, the gases can't get through there as easily. Emphysema, we actually blow these alveoli out. So patients struggling with emphysema, it's like the little grapes have just been busted apart. So the interface gets all messed up. Pulmonary edema, this is what happened with a lot of the COVID cases we had years ago. They get so much fluid starts to build up in here. Now you can just maybe appreciate you got a much greater distance. You're trying to get these gases across. So people are going to have serious trouble just getting ventilated properly. Okay? But these distances here, so keep that in mind, the thinness and the massive area. When you've got blood passing over half of a tennis court, it's like within fractions of a second, this transfer is occurring because of the massive surface area. And it's just another thing the body does in its elegance of giving us redundancy. People can live with just one lung. You can trash the snot out of your lungs and it'll still continue to function for the most part. Okay. Another basic concept, and you may have had with all of these things, some of this stuff may be old school, you've had it, you got it down, there may be some new stuff in here, but fundamentally related to all of this is the whole concept of atmospheric pressure. And I should have converted these to millimeters of mercury, but typically standard atmospheric pressure, the pressure exerted by the atmosphere on the surface is right around 760 millimeters of mercury. Okay, and then it reduces the higher up we go. So if you're on Mount Everest, you're down maybe 60%. It's dramatically less. That's why you need bottled oxygen at those high levels if you're going to breathe. And this is where we get our units of pressure from. So if you think about, if you had a column of air, 1 square inch, 1 inch by 1 inch, maybe 50, 60 miles up in the ionosphere, that weight of that column of air would be about 14.7 pounds per square inch. And that converts to 760 millimeters, 2992 inches of water. So the weather people, when they're talking about barometric pressure, high, low pressures, that's what they're referring to. Some weather people will talk in inches, water, others maybe 7 millimeters. But it's the actual pressure exerted by the atmosphere. And that becomes a significant issue when we're looking at some lung function stuff here coming up. Okay. The whole concept of partial pressure of gases, and this is Dalton's law, we'll see coming up a little bit, but the pressure exerted by that column of air is simply the sum of the pressures exerted by each gas in that mixture. So in our typical room air, about 21% of our air is oxygen. So the partial pressure is what PO2 is. Partial pressure of oxygen is about 21% times 760, or the amount of pressure due to the oxygen in the air is about 159 or so millimeters of mercury. And here's where this is kind of the essence of how these gases move throughout the body. It's because of these differences in partial pressures. Just like current and voltages in an electrical circuit, if you've got a voltage difference across a resistor, you're going to get a current flow. Same exact concepts with gases. If we've got a difference in pressure on one side of a membrane versus another, that higher pressure is going to force those gas molecules across the membrane. And that's exactly what we have going on here, and we'll see more of this coming up. Because we have a higher partial pressure of O2 in the alveoli than we do in the incoming venous blood, we've got a delta PO2 there. And that's going to be the driving force to get oxygen into the deoxygenated blood. And then similarly, there is a higher partial pressure of carbon dioxide in that venous pulmonary blood than in the alveoli, which is going to push the CO2 out of the body. And at the level of the cells, this is where all of the whole point is, obviously, is getting nutrients to these respiring tissues, as they're called. I mentioned it last time, it's kind of maybe a gross analogy, but our circulatory system is kind of like a train, a boxcar carrying food and waste in the same car. You know, I mean, in the same car, we've got nutrients, oxygen, things the cells need, but the cells are peeing and pooping, creating all kinds of trash and garbage. We got to get rid of that. And that's at the level of the capillary. The cells are offloading that garbage, waste products, which CO2 is one of them, but in offloading, bringing in the nutrients. So all of that's going on kind of simultaneously. And it's like the boxcar, the blood when it's leaving the heart at relatively high velocity at the level of the capillaries, the velocity of blood at the level of the capillary slows down dramatically. So it's like the train going into town slows very, very slow, so all of this transfer stuff can take place. Same concept, just another little way of illustrating it. So coming from the pulmonary artery, again, the cells have sucked out a lot of the oxygen out of the blood, so PO2 incoming is relatively low, relatively high in the alveoli, quite a delta PO2 there, 60 some millimeters of mercury, and that alone is what can force O2 across those membranes into the blood. Same thing with carbon dioxide. And the whole process just continues to work. This looks chemically a little chewy, but the whole essence of it is, again, oxygen coming in. Again, we got two little membranes from the alveoli, from the capillaries, pulmonary capillary. We got O2 coming in into the red blood cell. And this is what our pulse oxes do by looking at oxygen saturation. It combines with hemoglobin. There's all kinds of other chemical and enzyme things going on here, but oxygen binds with the hemoglobin, and that's how oxygen is transported throughout the body. And carbon dioxide, primarily about 70% of it is actually traveling in the plasma as a bicarbonate ion. And only when it gets to the lungs, that bicarb goes back into the red blood cells, activated with an enzyme, converted into CO2, and then it's sent back out to the body. And about 7% of the CO2 is dissolved in the plasma, and the rest of it's actually attached to kind of a form of hemoglobin. Whole variety of different gas laws, and these are all just from basic physics, these different laws, but they all have direct application and applicability to explaining how things are going on actually in the heart. I don't think I have a separate slide on it, but Poiseuille's law, you may remember that from physics. This applies to fluids as well as air as well. But the nature of that law explains how incredibly sensitive diameter of the tubes are to airflow. It's a radius to the fourth power. Flow is a function of the radius of the fourth power. So if we would just double the size of an airway, for example, the flow increases like 16 times. This happens with blood flow at the capillaries as well. Small little changes in diameter, radius, dramatic effect on flow. If you ever tried to suck a McDonald's milkshake, with a little small straw, you're creating a ton of vacuum trying to get that milkshake up, but a slightly larger straw will make a dramatic improvement in your ability to get that milkshake up. Very, very wildly powerful concept. This is how our bodies control blood flow too, to capillary beds. Just small little changes in the vessels, big flow, like why bronchodilators work. You get a small little increase in your bronchi airways, you can breathe again. But fundamentally, Dalton's law, again, some of the partial pressures. And again, I try to emphasize, we don't often have to get worried about all this minutia stuff and a lot of the math and the ultra detail, but just having an appreciation that the pressures, partial pressures, is made up of primarily air and nitrogen. That's the essence of what makes it up. Boyle's law, this works in the physical world as well as in the physiological world, but it just shows the relationship between pressure and volume, and this is exactly what happens, we'll see coming up, I think, too, when we inhale, we're increasing the volume of the chest cavity, the lungs, and with increases in volume, pressure goes down. And so the pressure inside the expanding volume goes down, atmospheric pressure is constant, that's going to be the driving force of getting air into the lungs because of this slightly small change in lung pressure because it increases in volume. Charles' law also explains why just in the process of breathing, warming our air, just the process of warming the air will increase its volume. So in the process of warming the air, that's creating it's a small amount, but it's a significant contribute to expanding the volume of the air in the lungs. So all these different laws. Henry's also, if you guys work on any kind of laparoscopic insufflators, we use CO2 to inflate the abdominal cavity. One of the reasons we use CO2 is because of Henry's law and taking advantage of the fact that carbon dioxide is sometimes 20 sometimes more soluble in water than oxygen. So it's very easily absorbed by the body, CO2 is. So it's a great gas, in other words, and it's, of course, doesn't contribute to fires and things either. Okay, but it's this atmospheric pressure is what's driving the pressure for inspiration. So if we create a pressure in the lungs slightly below 760 or whatever it is out here, we're going to be able to get air into the lung. Yeah, it expands just by Boyle's law. Since we have a slightly higher atmospheric pressure than we do in the lungs, we get airflow into the lungs. And then just the opposite occurs during exhalation. We create a slightly higher pressure in the lungs than the atmosphere, and it's only a few millimeters of mercury. It's all it takes. It's just that little small delta P, and we can get air into or out of the lungs. Of course, a whole host of muscles play a role during inspiration. All these different intercostal muscles play a role in moving the ribs out, which expands the chest cavity. Diaphragm descends, increasing the volume of the lungs. And again, that allows the airflow in. So you can see this is kind of what the problem happens in quadriplegics, especially, that we get paralyzed from the neck down. All these muscles are not working now anymore to assist in breathing. So they have to be, it makes them ventilator dependent. Have you ever had pulmonary function tests? We hooked up to some of these things. These are just pneumotacs, they're typically called. They're basically, sometimes they can just be a differential pressure transducer on either side of a little venturi, or they can have a little screen inside there where we're measuring a pressure on either side of the screen. So airflow moving past the screen creates a small pressure differential across the screen, and we can derive flow, airflow from that. And with a typical pulmonary function test, you just breathe into these devices. These are laptop-based machines, relatively simple, straightforward machines, but we can get a whole host of metrics that are very, very revealing about this overall lung function status. So just quiet breathing, okay, through these machines, very cyclical, sinusoidal, and the total volume associated with that breathing is what is our tidal volume. And this is a setting also on the ventilators. You've got a setting on the ventilator for setting tidal volume, and depending on the size of the patient and their condition, every RT and unit has probably different guidelines that they use. They might start out at 300, 400, 500 mLs tidal volume, and we can control that through the ventilators. We can measure maximum inspiratory reserve capacity, and if you have the patient take a maximum inhale and then maximum exhale, the total volume of air is again their vital capacity. And then anything left over, we all have a residual volume that you can't access. That's a little bit left in the lungs that you simply can't get at. We don't have access to that, but it's in the lungs. But all of these different capacities and volumes all can be obtained from these basic tests. Works real well. Yeah. Okay, so it's just the same definition, these different volumes. And again, if you went in for a complete pulmonary function workup, these are what would be actually, and there's a ton of normative numbers out there. So for your gender, your height, weight, they've got standardized values, so they very quickly can determine where you fit in all of this. And of course, if you're off, like what we can also get from the same data, it's like all of these values here, this is a function of time. So you're just quietly breathing. So on the x-axis is time. So we're seeing volumes as a function of time, but we can also measure flow as a function of volume. These are called flow volume loops. So while you're quietly breathing with the same device, your tidal volume would describe a little circle here, changes in volume with flow, and then they would have you do a maximum inhalation, maximum exhalation, and we look at the shape, peak flow, you blow it out, maximum inhalation, maximum exhalation, and you get a loop, flow volume loop. And again, normative values out there, this is what you should kind of look at. But if you've got any kind of obstructive diseases, emphysema, COPD, kind of asthma, even bronchitis kind of thing, you'll see cupping in here. So you'll see dramatic restrictions. You can't get air in or out during these obstructive diseases. And more restrictive diseases, if you've got problems with your chest cavity, your wall, you'll see the vital capacity be dramatically reduced just because you simply just can't. You've got something that's preventing you from fully exhaling, inhaling. You get that from the flow volume loops. Okay, and from your ventilators, an old Siemens. You guys still see any of these old Siemens around? They were kind of workhorses. Any of you guys used to work on them? The old C's and D's 900s? I actually kind of loved them in a way because they were so stinking easy to kind of work on. You know, they take the cover off. They had these 1,000-hour cal kits or something. I mean, they were relatively workhorses, but the concept's exactly the same, even with the newer technology. That expired minute volume is the product of the tidal volume, which we can set 300, 400, 500 mLs, and the respiratory rate, so you can control that. One of the problems we had with and you guys were probably, a lot of you were around during the COVID years, when first COVID hit, the medical community didn't quite know what to do with these patients. You know, if they were going really south bad, they put them on a vent, but they didn't know how to best manage the ventilator. So we can use the ventilator. If you overdrive, you can create volume trauma, where you can put in too much volume, or you can have too much pressure, barotrauma. You can actually destroy, lung tissue, depending on patient status. And sometimes these patients were so dynamically changing that it was really hard to keep track of. Okay, any of your hospitals have hyperbaric chambers? You guys using hyperbaric? Some of you do. Are they monoplaces, or you got the big multi-place ones? The big mono? Yeah. Okay. These are wild devices, and not everybody hospitals have these things. And they're kind of an orphan branch of medicine, if you will. There's not a big branch. There's not a lot of devices out there in their community that are compatible with these chambers. But there's some wild effects that happens if we would put you into one of these monoplace chambers, and mono is just for one person, we'll see. And they use 100% O2 in these chambers. So they'll pressurize it to 2 or 3 times atmospheric pressure. And what happens, of course, when you do that, is you've got now a massively enlarged pressure gradient than you would at, say, just normal at sea level. Tremendously greater gradient with that. And what happens when you put patients into those environments, the PO2 is so large that it literally will force itself into plasma. Normally, oxygen isn't that soluble in water and plasma, but you can essentially saturate the plasma with oxygen. You essentially wouldn't even need any blood cells for a while. I mean, there's the plasma gets saturated with O2, and the wound healing effect that has, because there is such a higher concentration of PO2 in the blood, the oxygen can travel much farther away. So if you've got damaged necrotic tissue, for example, at physically quite a distance away from a blood supply, the significantly higher pressures of PO2 can get to that damaged tissue a lot easier. And this is some of the kinds of conditions that legitimate. There's some fake stuff. I think I've seen some clinics and stuff. There's some kind of questionable places that are claiming to offer hyperbaric treatments for who knows what, but these are all legitimate uses of hyperbaric medicine, especially wound healing. It's almost one of the only ways we can treat some of these really, really nasty wounds because they're just so resistant to conventional treatment. But under hyperbaric conditions, we're forcing the O2 in here and we can do a lot of really good things. It's also one of the few ways we can treat carbon monoxide poisoning. If you get exposed to too much carbon monoxide, the hemoglobin in our blood likes carbon monoxide like 200 to 300 times more than it does oxygen. So the affinity of our hemoglobin for carbon monoxide is like 200 sometimes higher than it is for oxygen. So given the choice, the hemoglobin, oh yeah, give me some of that. It's going to forget the oxygen. And the only way we can effectively treat that is we can put you in a high pressure environment like this and just literally force that CO off of the hemoglobin. But it works really well for some of these conditions, especially again, diabetic foot ulcers and these nasty wounds that don't heal. So you may have heard some horror stories. In fact, I think there was just one, I don't know where this was, maybe Florida or somewhere, maybe just in the last year or so, there was an explosion in here. And you cannot survive this. It's like Apollo 1, was it, the astronauts? They were in 100% their Apollo 1 capsule. There was a spark or something, and it just incinerated. You can't put out a fire in 100% O2 environment till its fuel's gone. But that's what they have in these chambers. So no electrical devices are used in here at all. There was another case, I think it was in France, 10 years ago maybe. A grandmother went in the chamber with her little grandson just to calm him down, and they gave the little kid a toy to play with. Well, the toy was one of these cranking, sparking little toys. Created a little spark and just incinerated them. Because these things are pressurized, you can't just instantly turn the thing off. You got to purge the thing. It takes a fair amount of time to get the pressure down before you can open the doors back up. So, and alternatively, there are larger chambers, multi-place chambers they're called, where they'll use supplemental oxygen. The patients breathe, but they don't have, they're not 100% O2. So it's regular room air, 21%, but at a higher pressure, 2 to 3 atmospheres, or even higher if need be, in these multi-place chambers. At my last hospital, they had a big facility, and they actually ordered a new chamber placed from Australia. This thing came over on a boat, and they actually had to bust the sidewalk open in front of the hospital, drop this entire chamber down, this whole big chamber here, dropped it in, and ultimately finished it off so it looks like a regular room kind of a thing with a control panel. And everything was about 2009 when this was put in. So they've got individual treatment chairs, monitors in here. And every one of these monitors are purged with nitrogen as an added element of extra safety. That is, if you got anything hot in there, anything sparking, it's purged with an inert gas like nitrogen. And so it added an extra level of safety. Well, they also wanted electrical power in here, 120 volt electrical power. And they wanted that in there because this is a fairly sophisticated facility department at this hospital, and so they were kind of out there doing more things than a lot of other places were. They wanted electrical power in there, and the state said no, until you get somebody to properly design it, we're not allowing it. They're not going to let you operate. So I had already left. I used to be the director of clinical engineering there, but I left about 10 years prior to this or so. They came back to me and said, could I come up with a design to put electrical power in the chamber? Every one of my colleagues at my university said, are you nuts? Don't even think about doing that. If there's a problem with this, you are dead meat. They're going to sue you. You're going to bankrupt. Don't even think about doing this. And I thought, these people need electrical power in these chambers. There's got to be a way to do it safe. So I went back through, you remember the old NFPA 56? There used to be a bunch of NFPA codes out there on flammable anesthetics and ORs and stuff back in the old days. And when they used to use ether, well, I basically went and because I kind of grew up in that era where I had to do these stupid ass conductive floor tests. You remember that? You guys remember that way back? Every month, and this was up into the 70s, the mid 70s, it still used to be a Joint Commission requirement. Every month you had to go up there and do resistance checks of the floor. wasn't it?
Measure.
Yeah, yeah, like two 5-pound weights, 3 feet apart. Take resistance measurements of the stinking floor every month. And I just was a young, stupid kid, just graduated at my first hospital job. And the electricians, maintenance guys were doing it faithfully. They had log books every month up to, they had all impeccable records they had kept. And I said, well, I'm going to be up there doing the biomed stuff, you know, the bovies and the other equipment. I'll take it over. And they said, have at it, you dumb little bastard, you know, go for it. And so I started doing it. And I started thinking, what in the living, what the hell is this? What am I doing this for? It took me like a half a day. You had to go around, you know, you stick in measurements everywhere. And I did it for, I don't know, 4 or 5 months. And I finally said, shit, I'm not doing this. I got no time for that crap. And so I quit doing it. Less than a year, the Joint Commission came in. First Joint Commission survey I was ever in. And I had a little hole in the wall, an office down in the basement. And the surveyor came down with my boss, the administrator. The very first question the guy asked for, well, can I see your conductive flow records, please? He said, well, we used to do them, but we don't anymore. Oh, did I get it? Boss called me in there and, who the hell do you think you are? You know, boom, boom, boom. Just ripped me a whole new one and almost fired me. And I said, it's stupid. It's stupid. Well, it wasn't my call. It was still a Joint Commission requirement. But enough of us eventually in the community started bitching about it, and they finally got rid of it. Because when did they stop using flammable anesthetics? 40s or something, you know? But anyway, we finally, but I just basically followed all of the same guidelines that the old ORs were. So I found some really high-end explosion-proof receptacles. They're like almost $300 a piece, isolated power, had disconnect systems in there because they've got these massive deluge systems. If there is a fire in there, these sprinkler heads, these are not sprinkler heads. They're like fire hydrants with no, within seconds, you can have a half a foot of water in the chamber. I mean, it just floods everything. So I had it set up that if that was activated, it disconnected the power instantly. But anyway, with that same group, their biggest concerns, and if you ever had ultimately work in these areas, most of the devices that we rely on, our clinicians rely on in our ICUs, are needed by these multi-place chambers. They've got critically ill patients that need pumps, they need ventilators, they need monitors, but virtually none of this stuff is designed for use in high pressure environments. And often if you go through their manuals, it'll explicitly tell you not for use in hyperbaric environments. Do not do it. And so none of the devices are out there that are designed to do it, but our hospital needed the stuff. And fortunately, the primary hyperbaric safety guy was somewhat of a renegade, kind of like I was, and many of you guys, you know, we just say, we're going to do whatever we got to do with that, you know. So, and I mean, it was modifying devices. Many of these devices, if they had membrane keypads on them in closed airspace, you put it in a pressurized environment, you had no control. The button might just press by itself. As soon as you pressurize it, the buttons would go off. So I remember there's some things I'd actually get a little dental drill, and I'd drill a hole in the space behind the button to equalize the pressure. All kinds of little subtle stuff to make these devices, the telemetry, some of the GE telemetry we put in there. Actually put an antenna, one of the GE antennas in the chamber itself, so they could bring their telemetry patients into the chamber. And you know, they got all wigged out about that, and I had to open up one of the antenna, and it's just a passive F-plane piece of copper. You know, there's no active things in there. They're not going to blow anybody up. So it just took some engineering to looking at these devices. Certain batteries, obviously, you can't have in there, but anything that had enclosed air spaces, anything that would get warm, you can't be charging batteries in these environments. So there's all kinds of little subtle stuff that were very, very restrictive. And unfortunately, the hospital was so eager for us to continue to do this, they donated this old chamber to us, and I ended up spending a whole summer modifying the whole thing so we could bring in devices in here and we could monitor temperatures, pressures, we could videotape what was going on. I used to do experiments in there with bringing in some soda pop, carbonated stuff. You stick it in the chamber, you squeeze all the, you know, make the bubbles go away, kind of thing. Balloons in there, you could make them shrink and expand, but it was a effective tool to do some of that work with. So I think that's kind of fundamentally it. And again, it doesn't take a lot of, you know, deep rocket science to get, but as much as you can learn about what they're doing, your whole your whole credibility can continue to rise. You may have places in your own place, you might be some of them. You've got some clinician departments out there that they won't let anybody else touch their equipment except Joe. If he's on vacation or she's on vacation, well, I'm going to wait till they get back. And that's kind of an understandable level of trust that if you can get to that point, we're doing that much more for everybody. So, okay. Any questions on anything? Some of it old, some different maybe, or yeah. Anyway, we don't use that anymore, but worked pretty cool. Okay. All right, that's all I got then, unless you've got something else going on. Again, I hope you have a great rest of the conference. And again, by the time you leave here, I'm hoping you're going to be a few pounds lighter emotionally than when you came in. You're ready to take them on again when you get home. So, all right, thank you.